My name is Pei-Ni Jone. I'm a professor of pediatric, director of the Echo Lab at Lurie Children's Hospital, and affiliated with Northwestern University Feinberg School of Medicine. My co-author here is Adriana Tremoulet.
Hi, everybody. I'm Adriana Tremoulet, professor of pediatrics at the University of California, San Diego, and I'm also the associate director of our Kawasaki Disease Research Center and a pediatric infectious disease physician at Rady Children's Hospital in San Diego.
In our paper, we have a very nice figure that talks about the management of MI patients. The risk of myocardial infarction in Kawasaki patients with giant aneurysms is highest is actually in the first 2 to 3 months after KD onset. Acute coronary symptoms may present differently in our KD population compared to the classical presentation of MI in adults. All medical centers who follow KD patient with giant aneurysm need to have a multidisciplinary heart team and a protocol in place to address these major adverse cardiac events. In this paper, we also have documented on different risk criteria of coronary artery patient, how they are managed in terms of echo in the hospital setting.
For patients who have coronary artery abnormalities, long-term surveillance is really important, especially in any child that has a large or a giant aneurysm 1 year after KD onset. This could be performed with a low radiation CT, for example. There's been advances in MRI imaging, or even in those rare cases where invasive angiography may be needed depending on the coronary complexity and also any clinical symptoms that the patient may be having. There have been a number of advancements in coronary CT angiography with less radiation. So when that's available, it can be used to understand the anatomy at baseline for following these patients over time and to identify any coronary artery stenoses that may happen. The other area that's really advanced as well has been in CMR coronary imaging, which has really been able to evaluate our patients without the need for radiation. Or in that case is better for myocardial functional analyses, in addition to stress perfusion imaging as a modality for inducible ischemia. So we do have technologies that have developed that are much better for following our patients. There's also room for stress echo, and that can be used to evaluate KD patients with coronary artery abnormalities for inducible ischemia. And finally, invasive coronary angiography provides the finest delineation of the coronary architecture. Stress echocardiography can also be used to evaluate KD patients with coronary artery abnormalities for inducible ischemia. It's also important to know that invasive coronary angiography provides the finest delineation of the coronary architecture, although this really needs to be balanced against the risks of this invasive procedure based upon the patient and institutional factors. It is used for patients with myocardial ischemia and intervention for revascularization.